Good afternoon, dear colleagues. I'm Alexander Kancsev and I'm a psychiatrist, and I would like to introduce you my PhD topic. The title of my PhD topic is The Association Between Metabolic Syndrome and Cognitive Dysfunctions in Schizophrenia. I work as a psychiatrist, and my vision is that I hope in the future schizophrenia will be a manageable condition and will be compatible with a fulfilling life. And to achieve my vision, my mission is that I would like to fully elucidate the relationship between metabolism and cognitive dysfunctions in schizophrenia. Related to my PhD topic, we are currently working on two projects. In our first project, we are investigating the effect of impaired glucose homeostasis on cognitive functions in schizophrenia. In our second project, we are investigating the association between cognition, visual dysfunctions, and metabolic syndrome in schizophrenia. I would like to introduce you our first project. Some sentences about the background. Schizophrenia is a very severe chronic lifelong psychiatric disorder. The prevalence is around 1%. That means millions affected worldwide. The prognosis of the disease is very bad. That means these patients have a 20-year shorter lifespan. 25% of the patients have a suicide attempt during their life, and they live with impaired functionality and productivity, mainly due to the cognitive dysfunctions. To make the prognosis even worse of the disease, these patients are more likely to develop comorbid metabolic conditions and diseases. For example, the prevalence of insulin resistance is 2 or 3 times higher than in the general population. And it is really important because diabetes is linked to worse cognitive impairment in schizophrenia, but this has yet not been shown for the beginning stages of the diabetic spectrum. So our aim is to investigate whether the early stages of the diabetic spectrum have an effect on the cognitive functions of these patients. Our clinical question is impaired glucose homeostasis a risk factor of more severe impairment in patients, more severe cognitive impairment in patients with schizophrenia? We use the PICO framework. The population is patients with schizophrenia. The exposure is the impaired glucose homeostasis. The comparison is the physiological glucose homeostasis, and the outcome is the cognitive test scores measured by any validated cognitive batteries or test. Our hypothesis is that impaired glucose homeostasis worsens cognitive functions in schizophrenia. If our hypothesis is true, it will have many clinical and research implications. First of all, in the everyday practice, we have to measure the different glucose metabolism parameters in the laboratory. For example, we have to measure the fasting insulin levels, the fasting glucose levels, the hemoglobin A1C. We have to calculate the Homeyer index, and if we find any disturbances or abnormalities, we have to treat these conditions as soon as possible with every therapeutic options that we have. For example, change the diet of the patients, enhance the physical activity of the patients, and if it's needed, we have to use anti-diabetic drugs as an adjuvant therapy. On this slide, you can see the flowchart of selection. After the selection process, we ended up with 33 eligible full text. And I would like to show you one of our outcomes, a comparison between two groups, schizophrenia with versus without diabetes in global cognition in standardized mean differences. You can see the studies to the left from the no effect line, where patients without diabetes had the better cognitive performance, and on the right side to the no effect line, you can see the only study where patients with diabetes had better cognitive performance in the tests. It's not a statistically significant result, but it's clinically really relevant because most of the studies to the left from the no effect line. Our meta-analysis, we have a lot of strengths and limitations. The strengths are we have a large sample size, a great number of included studies, and this will be the first comprehensive analysis of the relationship between glucose metabolism dysregulations and cognitive dysfunctions. And the limitations are, it's really hard to put the different cognitive tests together in the analysis. Another limitation is the confounding factors. There are a lot of confounding factors. For example, the illness severity, the severity of schizophrenia, the severity of diabetes, the length of untreated psychosis, the length of untreated diabetes could also affect the results, the compliance to the cognitive examination, the different type of medications, for example, what kind of antipsychotics the patient take, or the different antidiabetics could also affect the results. And the other limitation is our analysis mainly based on observational studies. Here you can see the status of our manuscript. We are writing it right now. And our second project is investigating the effects of metabolic syndrome and its components on cognitive functions in schizophrenia. I would like to shortly introduce the background. It's really similar like in the first project. As I mentioned, cognitive impairment is a hallmark of schizophrenia that is significantly correlated to the functional outcomes of the disease. Moreover, schizophrenia appears to be associated with the metabolic syndrome diathesis, and is sadly exacerbated by the antipsychotic therapy. And metabolic syndrome and its constituent medical criteria are risk factors for clinically significant cognitive impairment. In a Hungarian sample, we can use the R1's cognitive battery to measure the cognitive function of the patients. It's a comprehensive cognitive battery. It consists of 12 subtests that provide 5 individual domain scores for attention, short and long-term memory, for language and for visual spatial skills. And our aim is to investigate the effect of metabolic syndrome and its components on cognitive functions. Our clinical question is metabolic syndrome and its components a risk factor of more severe cognitive impairment in patients with schizophrenia? We use the PO framework. The population is patients with schizophrenia. The exposure is the metabolic syndrome and its components, and the outcomes, the cognitive functions, in this case, the R1 scores. Our hypothesis is that metabolic syndrome and its components worsen cognitive functions in patients with schizophrenia. The clinical and research implication is really similar like in the first project. We have to prevent the more severe cognitive impairment in these patients. So if we find any comorbid metabolic dysregulations or diseases, we have to treat them as soon as possible, and we have to prevent to develop these conditions. Here you can see the sample characteristics of our study. We investigated 155 patients. The data collected in 3 clinical Hungarian sites. All patients were stabilized on antipsychotic medications, and 57 patients met the American Heart Association criteria of metabolic syndrome. Here you can see the comparison of sociodemographic and clinical variables of schizophrenia with and without metabolic syndrome. We found significant differences in BMI and waist-to-hip ratio. It's not an interesting finding because it's the part of the metabolic syndrome, but we were also interested in the interleukin-6 levels of the patients because chronic low-grade inflammation is linked to schizophrenia and also to metabolic syndrome. And we found that patients with metabolic syndrome plus schizophrenia had the highest level of interleukin-6 levels. Okay, on this slide you can see the differences between 3 groups in the R1 cognitive battery in 5 cognitive domains. And as you can see, with blue you can see patients without metabolic syndrome, with red you can see the patients with metabolic syndrome, and with green you can see patients with metabolic syndrome plus diabetes mellitus. And the interesting finding was in 2 domains, in the attention and the delayed memory domain, patients with metabolic syndrome plus diabetes mellitus had the worst cognitive performance. And it was a really interesting finding. After that, we were interested in the interleukin-6 levels in the 3 different groups, and the highest level of interleukin-6 exhibited in the metabolic syndrome plus diabetes mellitus group, followed by the metabolic syndrome group, and the lowest level of interleukin-6 we found in the metabolically healthy group. So patients without metabolic syndrome. We did not find any significant differences in the CRP levels. And after that, we were interested in the correlations between the IL-6 levels and the different cognitive domain scores, and we found significant negative correlation in the attention and delayed memory domain. So what are the conclusions of the 2 studies? It's really similar to each other. Metabolic syndrome worsens cognitive function of these patients. Type 2 diabetes mellitus is the greatest risk factor for more severe cognitive dysfunctions. Metabolic dysregulations must be prevented as soon as possible in these patients, and we have to talk about or think about schizophrenia as a systemic disease, so multidisciplinary treatment is necessary. What are the implications for research? The further studies are needed to investigate the relationship between metabolic dysregulation, inflammation, and cognitive dysfunctions. Here you can see the manuscript status. We started it also. And I would like to finish my presentation with one of my favorite quotes from Albert Szent-Györgyi: "The key to happiness is not to get more, but to enjoy what we have and to fill the empty frame of our lives instead of enlarging it." Thank you so much.
I have several questions. The first one is related to the second topic. Why did you not use the cholesterol, LDL cholesterol data? Because it has a very close relationship with cognition, and everybody has it. So why you didn't choose it?
Yeah, because we are lack of that data. It is
yes,
understand
really?
the
We
cholesterol.
did not have in the hospitals in this data.
We are lacking of the cholesterol data.
Oh, it's a very pity. Second, going to the first project, you didn't show within the limitations that disease cause. Was it comparable in the 33 articles which you showed? Because I think it has a very big importance. How long is the disease course?
Yeah.
So did they have any data? Were you able to assess it?
And not really. So we just have 8 articles in the diabetic group, and we are lacking of data.
Okay.
So if I understand the question right.
Just that how long the disease course was in the different cohorts, if they had any data about the disease course, the length of the disease course.
The disease cause?
Course. How long?
Yeah.
Course.
Yeah, in some articles we have data about that. Yeah, it's really interesting. Yeah, and it's a good point. It's also a limitation. But most of the articles in the diabetic articles is chronic schizophrenia with a long disease course.
Yes. And what is the relationship of dopamine and glucose metabolism?
It's a really interesting question. For example, there are new findings that the frontal cortex could play a role in glucose metabolism. So it's kind of like a bidirectional relationship between the brain and the periphery.